My training and
Sorry.
okay. I'm originally from Virginia. I'm a University of Virginia undergrad graduate. Um, it's good to be back in that area for now. Following undergrad, I went and worked in a mass spectrometry laboratory for a little while, so I have a little bit of a analytical background that's gonna rear its head in the research a little bit. And then I'm a pharmacist by training. Um, Went to University of Pittsburgh for pharmacy school, and then the past 4 years I've been in a postdoctoral fellowship at Hopkins, working between the division of clinical pharmacology, behavioral pharmacology, and I'm hopefully defending my PhD next month. So I'll have a PhD as well. So today my talk is about the applications of clinical pharmacology to emerging psychoactive substances. For this audience, I'm actually going to give a brief kind of general overview. Clinical pharmacology is kind of the science of how drugs move throughout your body, and how you act based off of your exposures and how they move. So my talk is really focused on that in the field of emerging psychoactive substances. So what do I mean by an emerging psychoactive substance? I mean anything that is experiencing a resurgence in non-prescribed use. And so this could be a newly synthesized chemical. It could be something that was new to the recreational market. So like a failed pharmaceutical would be an example of that. Um, or something that's used medicinally that's now popular in the recreational market, or just something that um, maybe is used in other countries more, but is coming more into fashion locally. I would argue like kratom would be an example of that, where it's been used in Southeast Asia for a long time, kind of in a social context, but is a little bit more new to the United States. Um, why might someone use these? So honestly, the the most obvious answer is they have a desirable effect um, of some sort. It could also be, particularly in the sense of a new chemical entity, to avoid legal repercussions because it has maybe a similar effect to a drug that is considered illegal, but is chemically a little different, so it's not detected, or it's technically legal through loopholes. I'll maybe be talking about delta 8 THC. That's an example of a little bit of that. Um, or they might use these because that is the drug supply. The supply is adulterated. They're maybe trying to get a different substance, but this is what like a novel emerging psychoactive substances was what um, was, in the supply. Um, and these are really problematic because they have really poorly characterized exposure response relationships. So, and that's like clinical pharmacology right there, is exposure response relationships. So you get these adverse health effects, but you're like, well, why did that happen? Maybe there's an issue with detecting, like what, led to this clinical outcome that we see. Um, so that's why I'm interested in studying these and applying some of the tools that are used in clinical pharmacology and drug development stuff um, to really understand the exposure and outcome relationship of these. So today I'm going to be talking about two trials um, that I've led over the past couple of years. And we're going to start with this fentanyl and xylazine in the urine of persons with opioid use disorder. Um, so I've heard this audience is familiar with opioid use disorder, and I've worked with this population pretty extensively and probably seen this diagram a lot. But illicitly manufactured fentanyls have been um, kind of the causal agents behind a lot of opioid involved overdoses over the past 10 years, with about in 2022, a little over 68% of deaths attributed to opioids involving synthetic opioids, primarily fentanyl. I will note there's a really promising trend of this declining recently. This was just released from the CDC in February, but still the amount of kind of like problems this has caused is really staggering. And part of this is I would argue supply driven. So the kind of illicit opioid supply that's available in the US now is has shifted away from this diverted prescriptions and shifted away from heroin to more of the synthetic fentanyl analogs and fentanyl. And this can be seen, this is a trend analysis done by my primary mentor, Andrew Hoon, where they looked at the urine density of different drugs over time in urine drug samples submitted to a national drug testing laboratory, and it really kind of mirrored the shift in the illicit supply to fentanyl and away from heroin and to more concentrated like fentanyl in the supply. And this is also associated with more people who are presenting to opioid use treatment with what opioid use disorder treatment with what I'm calling fentanyl associated opioid use disorder, which I'm just meaning is they are primarily exposed to illicit fentanyl in their supply rather than historical heroin or prescription opioids. And it has a distinct clinical picture that I've listed a couple of unique characteristics here. But I'm a clinical pharmacologist, so to me, I was looking at this fentanyl associated opioid use disorder, and in my mind, I'm like, well, all of this can be explained by fentanyl's pharmacology, like all its properties, so to speak. And so I led this review a few years ago that was just looking at the properties of fentanyl from years and years of use in anesthesia and medicine and saying, hey, like this could be why we're seeing the consequences. So here are some of the properties, main findings that I found. So fentanyl is a extremely potent mu-opioid receptor agonist. So it acts at the mu-opioid receptor, and that causes some of the pain relief and stuff. It's a good drug in that sense that it's very effective at pain relief. It's extremely lipophilic compared to other opioids like heroin. And it's also highly distributed to tissues. So some of the previous studies have shown that fentanyl kind of accumulates in muscles and fat, especially over time. It's metabolized to an inactive metabolite, and that inactive metabolite is excreted in the urine. And then it has this really interesting, what's been described in literature as fentanyl rebound phenomenon, where people would wake up from surgery when they had just fentanyl on board that put them to sleep for the surgery, and start moving around and be in recovery. And all of a sudden they would have respiratory depression that was like, why do you have this respiratory depression? You were recovering from surgery, doing just fine. And in studies, they noticed it corresponded with the fentanyl concentration rising in their blood. So secondary peaks, that's what I mean by that. So that I took as that's showing that like all this fentanyl that's stuck in your muscles and fat is still like physiologically significant. If you're getting like a rebound phenomenon, secondary respiratory depression, like hours after your surgery. So really interesting there. But the reason that we were interested in this study I'm about to talk about was my mentor, Dr. Hoon, had noticed that people were testing positive on urine drug tests for a long time. And that was kind of unexpected. So what what does that mean? So when you take a urine drug test, the results are reported back as positive or negative. Positive meaning it was detected in the urine and you were presumed to be exposed to that drug within the detection window. The established detection window for urine and its metabolite, norfentanyl for urine, has historically been pretty short. Here's some of the laboratories reporting how long after your exposure you expected to test positive. But some of the case reports that have come out have noticed people were testing positive for like months. Particularly this one in pregnant and postpartum individuals. It's like you're testing positive for 6 months. And this is the study that was led by my mentor, Dr. Hoon, that noticed people were testing positive for up to a month. So we wanted to look more into this phenomenon, and we designed a study to do that. So notice I'm calling this original plan. We're going to get into how this changed, but the plan was to we were going to collect up to 4 urine samples daily for 5 days while participants who were reporting to a clinical trial were in our residential research unit. So they were being housed overnight with us. And we were going to use a really sensitive mass spectrometry method to quantify the amount of fentanyl, norfentanyl, and heroin that was present in these urine samples. And then the plan was to look at the individual detection times. So when did you start testing negative for fentanyl, norfentanyl, heroin? And the original plan was to examine this relationship with the onset of opioid withdrawal. So that was the original plan, starting in 2022. So I'm not sure if this audience is familiar with Xylazine. So Xylazine, this is, I thought, a really nice patient-facing flyer from the Philadelphia Department of Public Health. But fentanyl has increasingly been contaminated with Xylazine in the illicit supply. And this has been associated with, as this flyer points out, an increase in things like severe skin wounds or increased sedation. And if you look at the amount of samples that were submitted to a urine drug testing facility, I've highlighted here Virginia and Maryland. In fentanyl positive samples, Virginia has about 18% in this study had xylazine positivity, and Maryland had about 1/3 of samples submitted were of fentanyl positive samples were positive for xylazine as well. And it's the trends here in the map are the spread, the difference in the first 6 months after it was declared emerging health threat, and the second 6 months after it was declared a emerging health threat in the supply. So I gotta go on the pharmacology and all this. So xylazine is an alpha-2 adrenergic agonist, so it's not an opioid. I have here two other alpha agonists. Clonidine is actually used sometimes off-label to alleviate withdrawal symptoms in opioid use disorder treatment, and dexmedetomidine is another example of one used in surgery. And I'll also kind of a side note that medetomidine, the racemic mixture of this and another, is now appearing more and more in the illicit drug supply. But in rats, xylazine is primarily eliminated as metabolites in the urine, with an expected excretion half-life of 4.5 hours. And notably, the issue with this is really the human pharmacology is not understood, because frankly, the one study where they gave it to a human, they had such bad adverse events, such bad drops in blood pressure and heart rate, that they said, okay, we're not developing this for human use. But it is approved for veterinary use. So there's lots of animal data that can kind of inform, and this is my dog after he got stuck in a cone, just for fun. So back to the study I was describing. So our clinical chemistry collaborator had just developed a xylazine assay and was like, well, let's look, let's see if there's xylazine in these urine samples. And the answer was yes. There was a lot of xylazine in the urine samples, and I'm gonna tell you about that shortly. And then also in this study, the original plan, as I mentioned, was to look at the detection times, which this study had really poor attrition. So really not a lot of people were testing negative for these substances by the time they left. And examining the relationship with opioid withdrawal, I felt was not a fair analysis, so to speak, because a lot of people had xylazine exposure, which complicated the withdrawal picture. Really, there was not a lot of people exposed to heroin. And we also ended up, in order to keep these people in the study and manage their withdrawal, prospectively administering 30 milligrams of hydromorphone 4 times a day. So that kind of complicated the withdrawal relationship, so I felt it wasn't really fair to look at that. But what ended up happening was I performed a non-compartmental pharmacokinetic analysis on these spot urine samples that gave an estimation of the urinary half-life and the predicted detection time of these analytes in urine samples. And I'm actually going to walk through a little bit how I did that and what that means in my slides. So we enrolled 11 participants who were already enrolled in this residential clinical trial, but agreed to additionally provide urine samples 4 times a day for us while they were enrolled. And we collected 95 urine samples between May 2022 and January 2023. Participants were majority male of mixed racial background. And the majority of participants actually reported intranasal drug use primarily. And I think 2 reported primarily intravenous drug use. Farther, 10 out of the 11 participants had evidence of exposure to xylazine, and none of them had evidence of exposure to heroin. So this was trial participants who were exclusively exposed to fentanyl in their illicit supply, despite at the time we were thinking it was going to be a fentanyl and heroin mixture. So what do I mean by the analysis that I did? So this is like the urine concentration of norfentanyl, phenol, and xylazine over time since that participants last self-reported opioid use. So time 0 on all these axes is normalized to when the participant entered the study. We asked, like, when did you last use opioids prior to coming in? And they'd give us a time. And as you can see, I mean, they followed a pretty like clean pattern for spot urine samples. And so we kind of fitted this line to them. And the urinary half-life has to do with the slope of the line for people unfamiliar. So that has to do with like how long the time it takes the concentration to decrease by 1/2. And then we did a predicted detection time, which was the time from their last self-reported opioid use to our limit of quantitation for the assay, which was 5 nanograms per milliliter in this case. And that has to do with that where the line intersects that line. So, and that's in case you were wondering, the math to do with that, I'll have up there as well. So in order to make sure that our predictions were accurate, we only included people where basically like the line explained a lot of the variability and we could like fit the line. So this is an example of a participant where that R squared value, which is kind of measuring the fit of the line there, was really poor. 1 is like excellent fit, 0 is like no fit. So in the pooled analysis where I predicted the detection time and urinary half-life, we only used participants with an R squared greater than 0.4. So that's why I don't necessarily have 11 participants in the pooled analysis. We also we did this both unadjusted and adjusted by creatinine. So creatinine is something that's it's excreted in the urine, and it helps account for kind of fluctuations in urine due to like hydration status and things like that, because you assume that it's excreted kind of at a regular rate. So in some participants like this, that helped the line fit better, and so the creatinine adjusted estimate was able to be used. So here's the pooled everybody. I realize this is a bit of a data dump, but what I want to get from this is really an appreciation that there was a lot of variability in the excretion patterns of individuals, as seen by the fact that the urinary half-life, so the slopes are different based on the participants, and the predicted detection times were also different based on the individual, and that depends on both the slope and the equivalent of the x-intercept, so how much kind of concentration they had at the beginning. Also here I have reported for those individuals that actually stayed in the study long enough to start testing negative for the analyte in their urine. I have on the far right the equivalent of the last positive urine sample and the first negative urine sample. So despite the fact that a lot of our participants didn't stay in the study long enough to provide like a negative urine sample, the predicted detection time was pretty spot on for everybody that was able to be confirmed, kind of showing that, hey, like this analysis is novel, but like has utility in that sense. Then same thing for norfentanyl. a lot of inter-individual variability here. The creatinine adjustment here helped explain a lot of the variability in the urine samples that kind of made the line not fit. But in this case, we weren't able to confirm anybody just because norfentanyl is detected for so much longer. And then finally, xylazine. Again, a lot of inter-individual variability here in the urinary half-life and predicted detection times. And we were able to confirm a couple of people's detection times here. And so in the resulting publication, I just reported the mean, median, range number of participants who contributed, and had all the information about like here are the patterns all together. So this was just published at the end of February. And to my knowledge, it's the first characterization of the urinary pharmacokinetics, the urinary excretion of fentanyl and xylazine in this population who's exposed to illicit fentanyl. And I think it's the only paper giving any sort of idea about the urinary detection window of xylazine, which is like I think it's longer than the animal estimates would, lead you to believe. And then from this paper, we concluded that individuals are presenting with a really high magnitude of drug exposure that lends to an extended duration of urinary detection compared to the medicinal exposure. So before I move on to my next study, are there any questions about this? Yes. I'll start with Jerry.
So you mentioned that muscle mass and fat are related to there's a big range of the concentrations over time. Was it related to directly related muscle mass, body mass, fat?
So since there were only 11 people and there wasn't a lot of heterogeneity there, I wasn't able to look, but let's just say it's something I'm very interested in looking at. If that is kind of a clinical correlate that you can say like, hey, somebody with a really high body mass index might test positive for longer, that's something to look for in the clinic, but couldn't quite prove it with this data.
In spite of the big range. It's a big range.
Yeah. And I actually have that all reported in the case report. Like they made me put it in the supplement, but all of the demographic factors and all of the detection times and half-lives, like age, sex, BMI, I did like individually report in case this could maybe be combined with somebody else's information along the way.
I had a similar question. Yeah. Clinically, we like clinically, the pregnant postpartum people, yeah, like I know that case report that you said at the very beginning, it kind of like made its way through our group. We deal with this all the time because these patients have open CPS cases and they just keep on testing them, but they don't know what they're testing. They just keep testing. I say child welfare. And so we have such wide variability. And so that's what my question was getting at was, were you able to look at any of the patient specific factors? I know you had a small sample size because like the postpartum people have a lot more fat, for example, right? They just had a baby, they're breastfeeding, etc. And so there's just a lot of questions on, are these individuals more prone potentially? I know there's a wide range and individualized, like you showed. Can we tell child welfare, like this person just had a baby, therefore this may be more likely to stay in their system because of these certain factors? Is there anything like you would say to someone asking you that question?
I think right now I like really want to investigate it more. I would say this is like preliminary data for that, but the answer is yeah, potentially, because like so much happens to your body when you're pregnant and postpartum. So it like all those physiological changes like might be contributing to just things coming out of storage in weird ways,
Yes, interesting. I think it was interesting for you to say that. I mean, that's what people worry about with overdoses too, right?
Mhm. Yeah, yeah, and I think it could be, there's a lot of things playing in with overdose that I'm interested if it's affecting that. Like you have the respiratory depression causing changes in pH. Like, is that playing into some of this, making your overdose worse? Or obviously like the interplay of all the different things involved in the illicit supply. It's not just one drug, it's all of the different mixture. So yeah, all this I'm really interested in. I would say this is some strong preliminary data and directions I want to go in the future and actually combine with the next, like a technique in I have the next study. So we can talk about that later. Yeah. Uh, were there other, I can't really see the chat.
Chat open.
Okay.
Anyone have any questions before she moves on to the next study?
I'll give a teaser for what the next study is. So. Okay.
You're good.
Seeing none. So this next study is really hot off the press. Comparison of Delta 8 and Delta 9 THC using population pharmacokinetics. So I will briefly touch on what is Delta 8, Delta 9. So Delta 9 THC, which I will be referring to some as just Delta 9, is the primary psychoactive component of the cannabis plant. Delta 8 is a structural isomer, and it is found in very, very minor quantities in the cannabis plant, but through kind of a legal loophole that happened with the passing of the Farm Bill, it has grown, skyrocketed in popularity, hemp-derived synthetic Delta 8 THC products, which in this case, I might just refer to it as Delta 8 in this talk, mixed with Delta 8 THC. So this is a really blurry version of an Amazon Turk survey that my colleague, Dr. Cecilia Bergeria, did, that basically asked people about their Delta 8 THC use. And some of the more, here I'm highlighting some of the more common modes or routes of administration with illustrations of what those look like. So a lot of people reported using flower, that's usually smoked or inhaled, using vapes, vape pens, or ingestion via edibles. So keep that in mind for the study. Also, a lot of people reported basically trying to self-manage medical conditions with Delta 8, which I think is fairly common. A lot of people reported trying to treat anxiety or stress with the use of Delta 8 THC. Another kind of epidemiological view of, well, how popular is Delta 8? So this is data from the National Drug Early Warning System. This is one of their releases where they basically go and they interview people on the street and they say, okay, what drugs have you used in the past 12 months or 30 days? And in Daytona Beach and Charleston, South Carolina, about 10% of people reported past 12-month use of Delta 8 products, and 8% reported past 30-day use. Further, there was another study looking at the monitoring the future data, where about a little over 11% of 12th grade students had reported past 12-month use of Delta 8 products. So this is a fairly popular product. It's kind of perceived to be a legal substitute for Delta 9 THC, so cannabis, which is illegal, but this is kind of in a gray area of legality. If we look at its comparative pharmacology, so I have actually the structures here of delta 8 THC on the top, delta 9 THC on the bottom, and they're like really structurally similar, right? Both of them act on the cannabinoid receptors, and honestly, both like from kind of a interviewing point of view have been said to have very similar effects. Delta 8's actually, I think, colloquially sometimes called delta 9 light, noting its lighter effects. They're thought to be pharmacokinetically similar, so that means similar in how they move throughout the body. But I'll note the receptor potency is generally the delta 8 parent is less potent than its active metabolite, and delta 9 and its active metabolite. So for those unfamiliar, what I mean by that, it's when it turns on the lights, it doesn't turn on the lights as bright as the metabolite in delta 9 and its metabolite, if that makes sense. And there have been very few human administration studies comparing these. So you'll note the direct comparison of delta 8 and delta 9. These are all much older studies. This first study reported delta 8 was 2/3 as potent as delta 9 based off of narrative reviews of drug effects, subjective effects, and a couple of physiological ratings. This second study also kind of reported the same thing. Delta 8 has effects that are less potent than delta 9, based off of some physiological measures and subjective effects. And then this third study concluded that delta 9 is about twice as active as delta 8, again, based off of heart rate, perceived time distortions, and subjective effect ratings. But you'll notice all these studies, there are no female participants, which is a problem in terms of generalizability. And none of them collected pharmacokinetic data. So none of them collected like blood concentrations to really like understand what's going on and why you're getting these differences in effect. So that was kind of why we wanted to do this study. So our objective here was to build a population pharmacokinetic model of delta 8 and delta 9 and their respective active metabolites. For those unfamiliar with population pharmacokinetics, this is like a way to quantify and describe how a drug moves throughout the body. It also quantifies between subject, within subject, and unexplainable variability. So that's like a huge benefit of this, is like what is causing the variability in differences in how this drug moves throughout the body between people or within an individual in different occasions. And it incorporates clinical covariates, which I think is one of the coolest parts of these analyses. And these models are used in drug development all the time to aid in future study design or help with certain regulatory things. So data for this model was derived from 2 randomized double-blind within subject crossover clinical trials, one of which was just published and one which is in press now. And really briefly, the experimental methods for these was it recruited a population of cannabis experienced, non-tolerant, healthy adults. And participants were randomized to either do the oral administration study or the vaporized administration study. So in each of these studies, in a double-blinded fashion, in a randomized fashion, they received 3 ascending doses of delta 8, a placebo, and a comparator dose of delta 9 THC. And then I'll go over the different effects. And all participants had to complete these 5 sessions separated by at least 6 days. So separated by a week. And basically exclusion made it so that there was nothing that they knew of that was going to affect the pharmacokinetics of either of these. An interesting thing about the study was that once a participant completed the 5 sessions of one route of administration, they had the option of doing the other route of administration. So that's gonna come in handy in this analysis. So we had a fair number of people that did 10 sessions with us. In the vaporized study, they were allowed to inhale and complete the dose at their own pace. But we measured what's called puff topography. So we measured like how they were inhaling, because we know that how people smoke and how they inhale will affect how the drug moves throughout their body. So what was measured here is average puff duration, which is like how long they are inhaling, average interpuff interval, so the time between one inhalation and the next that they're resting, and average puff volume, so that would be the volume that is inhaled per inhalation. We did pharmacokinetic measures, so this is just a timeline of when the blood draws were completed. In the vaporized study, there's one additional draw immediately after dosing. So when the participant finished vaping, they got their blood drawn and then was back on the same schedule as the oral administration study. I'm gonna walk through these steps, but we did a nonlinear mixed effects model of delta 8 and delta 9. And again, I'm gonna walk through these steps. Notably, this model, you have to look at them separately because they're separate drugs. So we built one model for delta 8, one model for delta 9. But since I'm kind of interested in comparing them, part of the data exploration, I added in a bioequivalence analysis. So just looking at the 20 milligram delta 8 versus 20 milligram delta 9 dose in participants separated by route of administration to look at if these are metabolized the same way or different, or are you getting different exposures? And this was done to kind of mimic a 2-period crossover study design that's a little bit more used more normally in a bioequivalence analysis. So results, a total of 23 individuals contributed to this model and analysis. 16 individuals completed both studies, so they did all 10 sessions. 3 completed just the 5 oral sessions, and 4 people completed just the 5 vaporized sessions. But this analysis will include all 23 individuals. We had a fair number of female participants, which was great because the previous studies did not include female participants, and a range of age and BMI values, which we looked at if those affected the pharmacokinetics in this analysis. So now I'm going to go through how you do this. Step 1 is just you explore the data. So this is looking at those puff topography outcomes. So how did people like change their vaping behavior? They were blinded to the doses, so they didn't know what dose they were receiving. However, you'll notice here in the thing I've highlighted, the 3 delta 8 doses, that there were dose dependent decreases in average puff duration, average puff volume, and dose dependent increases in the interpuff interval. So basically, this is getting at people were self-titrating despite being blinded to the doses. Because they could feel the subjective effects. Further, this is just a correlation to look at the effect of the puff topography measures on the x-axis plotted against either maximal concentration or area under the curve, which is like a measurement of exposure. So as the puff duration and volume increased, the exposure also increased. And as the inner puff intervals, so the time between inhalations increased, the exposure decreased. This gets a little confusing, so I'm making sure I say it right. So basically this is kind of getting at people were kind of self-titrating their smoking behavior based off of the perceived effects after their vaping. So I'm keeping that in the back of my head. This is kind of a dead slide of you do a non-compartmental pharmacokinetic analysis. Specifically here, I want to point out it following oral administration, you had time to maximal concentration 2 to 3 hours, pretty consistent with oral drug absorption. Down here, you had dose proportional increases in area under the curve as which is an exposure measure, like I mentioned, as evidenced by this normalized by dose being about the same. And then clearance, volume of distribution, and elimination rate constants were all pretty like steady across the doses of orally administered delta-8 THC. In contrast, following vaped administration, you had pretty much the first sample collection was your maximal concentration, which is consistent with inhaled absorption being really fast. You did not see this dose proportional like increase in exposure, as evidenced here by like this number is decreasing. It's not the same as in the oral. And then you also had these dose dependent changes in clearance volume, which kind of canceled each other out with the elimination rate constant being the same. But all this is getting at, oh, and you also had relative bioavailability decreasing as dose increased. So all this is kind of getting at the fact that combined with what we just saw, people were really like self-titrating the vaped dose of THC, and it affected their pharmacokinetic parameters. But the great thing about this analysis is that we can account for it because we measured it. So just to give you a heads up on that. Secondly, which I actually might need to grab my charger real quick if you don't mind. Worried I'm gonna right here. So we did a bioequivalence analysis. Just look at is like, are these metabolites the same way? Are you getting the same exposure to the delta-8 as you are at delta-9 and its metabolites at the same dose? So this is just a 20 milligram dose, where we looked at the ratio of area under the curve. And then the gray box, I tried to show what statistically would be if they were like the same, is the gray box. So that would be the bioequivalence margin. So the fact that the parent is lower here means that following the same dose, people had more exposure to parent delta-8 versus delta-9 in both routes of administration. But if you look at the metabolite, you had a lot less exposure to the 11-hydroxy delta 8 metabolite, which was more active than the parent in potency assays, versus the 11-hydroxy delta 9 active metabolite. So this is starting to get at they're metabolized differently in people, and we can't tell yet, but this could be a reason why you get different perceived effects. This is my first time going through this, so I'm kind of, or like with an audience, so I'm kind of like, I'm hoping I'm explaining this all right. So then the next thing we did was the parent structural model. So this is a model of how the drug is moving throughout the body. And basically kind of found that both delta 8 and delta 9 move throughout the body in a similar fashion, so similar structural model. But there were some differences here in these parameters, so peripheral volume of distribution, the intercompartmental clearance and total clearance. And basically what I wanted to get at here was that's starting to get at what I just showed you with the bioequivalence analysis, as like the model's picking up that delta 9 THC is going somewhere that's not the blood, which is kind of what I'll just leave it at that general broad. Yeah, I'll leave it broad like that. But the other thing here that as a parameter that I want to mention is this F. Like, why is everything divided by F? So F is bioavailability. For our model, we set the oral bioavailability as a reference, so that has to do with like kind of an absorption related in this case, but how much is like in your body to begin with. And when I'm talking about relative bioavailability, it's comparing the vape to the oral. So the oral is like the reference here, and the vape is compared to that. And we noticed, because people change their vaping behavior, that this relative bioavailability decreased as the doses increased, and we accounted for that in our model. Next thing is covariates. So I think this is one of the coolest things about this type of analysis, is that you can look at different parameters and see how they influence inter-individual variability in your pharmacokinetics. So I'm just kind of going to show all my cards here. You basically go through and you add in the covariate and see, like, does it help the model fit? And if it does, you include it. So here we went through and looked at the relationship between the covariate and the different pharmacokinetic parameters. And in this case, forward inclusion was for delta 9, age on the peripheral volume of distribution, and average puff duration on relative bioavailability. And then you do a backwards elimination where you have a more strict statistical criteria, and you drop things from your model and you see if how it changes the fit. So neither of these met statistical significance here. I started with the more boring one, but for delta 8, we went through, we looked at the same things. How does adding this covariate explain variability in this parameter? And here we found age, average puff duration, and average interpuff interval all explained variability in the relative bioavailability of vape doses. And then when we started dropping them, they were all statistically significant in terms of relative bioavailability. However, Average puff duration ended up not being included in the final model because I think it ended up like turning a lot of things negative that shouldn't have been negative, basically. And age also was dropped because it messed up all the other parameters, basically. But we ended up keeping average interpuff interval on relative bioavailability. I think it explained something like 20% of the inter-individual variability in relative bioavailability for vaped doses. And basically the relationship here was as the time between doses or the time between inhalations increased, the relative bioavailability increased, which isn't totally a direct relationship. I think it was more to do with people were feeling more drug effects and had to take more time between when they took inhalations because they were feeling stronger effects. And then I included how like the mathematical relationship there as well. So yeah, we ended up keeping average interpuff interval as a covariate on relative bioavailability in the final model. Then realize I'm running out of time, so I'm trying to kind of go fast. So we incorporated metabolites, Xylazine hydroxy metabolites, again explained by a 2-compartment model for the metabolites. And we noticed that the amount converted to metabolite was dependent on the route of administration. So more was converted to the metabolite following oral administration compared to inhaled or vaped. And we incorporated that route dependent fraction metabolized in the model as well. Finally, we evaluated the model with goodness of fit plots, visual predictive checks, and bootstrap resampling to get the final parameters. And I knew I was going to be low on time, so I literally just have generally idea of what you do here is like look at the predicted versus observed values, the weighted residuals over time, and if they're kind of falling in line with the pattern, you say your model's good. It's the long story short. And then visual predicted checks, you do 1,000 simulations and you find how you think the drug's going to move throughout the body, and you have kind of a 10 and 90th percentile where you think the upper and lower are going to be. And a lot of our actual data points were within this range. There was a couple of stragglers, but that's to be expected. And then we reported all the different model parameters here, which I realize is very dense, but I did want to say, like, this is what you end up with when you do this. So kind of summing this up, this is the first built pharmacokinetic model of delta 8. We used data from both oral and vaporized administration, which are 2 common routes of administration for delta 8 products, as shown by that Bergera study. We used a higher dose than some of the previous models of delta 9 THC, which is good for our external validity. We did include female participants, and we were able to do a covariable search, which found basically the influence of puff topography and how people were self-regulating their vaping behaviors, how that influenced the variability in the pharmacokinetic parameters. Some of the negatives here were we were not able to characterize the probably long terminal phase of delta 8 due to our sample collection, and our time to maximal concentration correlate, like it was the same as our first sample collection, so we really couldn't get that absorption phase well characterized. From this, we're concluding Despite the similar pharmacokinetic structure, delta 9 appears to be more metabolized to its active 11-hydroxy metabolites compared to delta 8 to its 11-hydroxy metabolites, which may explain some of the differences in perceived effects. Further, following oral dosing, more is metabolized than vape dosing in general. We were able to look at the effective participant vaping behavior on how that influenced the pharmacokinetics of delta 8, and captured the behaviors by dose-dependent covariables and average interpuff interval as a covariable model. And our checks that I know I kind of went through quickly were found the model was robust and reliable. And I wanted to end with a cliffhanger that they took pharmacodynamic measures at all of the time points here. So now that we have the validated pharmacokinetic model, we can add in the pharmacodynamic measures and really have a robust understanding of like the differences in delta 8 and delta 9 and the clinical outcomes and effects associated. And then finally, I wanted to just end on like my future directions personally. So like I would like to gain more experience with the design and implementation of early phase clinical trials. I have some experience through Hopkins, but we really like to learn more about how these are implemented. I showed you an example of a population pharmacokinetic model, and I would really like to learn more about these. I think that the possibilities in drug development or for looking at the basically like differences in individual clinical outcomes based off of like exposure response relationships. I think the possibilities could be really powerful using population pharmacokinetics or a different modeling technique called physiologically based pharmacokinetic modeling. I also just want to continue forming new collaborations. And then I'm interested in like transitioning from more of a mentee position to a mentor position and getting my own independent funding along the way. So I know I ran over a little bit, which is why I was trying to rush, but thanks for listening to those that stayed on. And thank you to my collaborators who helped with this and to all the participants who were involved in this research. There's my son and I at the aquarium. So yeah, I realized I got a little, I was trying to rush it towards the end, but if there's any questions, I'd be happy to answer them. If I can figure out.
So how do you administer the delta 8? What form does it in? How do you?
Oh, hold on. So the oral study was in chocolate brownie.
And did you all make it, or just a formulated kind that come prepackaged?
It was compounded by our investigational drug pharmacy.
Okay.
Yeah, so it was like from pure delta 8 and pure delta 9. They like individually made the brownies for the participants. Which makes the whole building smell delicious, by the way. Because our investigational drug services are like in the same building as us. And then for the vaporized study, they used the it's called the Mighty Medic like handheld vaporizer, and they had it like retrofitted with this measure, like the thing to measure puff topography. So it looked a little funky, but that was also compounded, like the dose was compounded by our investigational drug pharmacy, so it wasn't a commercially available product.
Okay. I just wondered how it was. I was like, what was it? A gummy?
Yeah, chocolate brownie.
A paper?
Yeah,
Plain.
yeah.
I had a quick comment and a question if there's time and if you can hear me.
Yeah, I can hear you.
Okay, cool. Well, about the like THC study, I just wanted to say that I think the puff topography outcomes are really interesting, especially breaking it down by dose. And I think there are a lot of people at VCU. I come from a preclinical pharmacology background who are trying to like reverse translate these models of vaping, and that's so helpful. So I really love that you did that and included that. Um, and also looking forward to the different pharmacodynamic outcomes from that study. Um, and then on the fentanyl, xylazine thing, I just had a clarifying question. So, I was wondering if you know if the fentanyl and xylazine combination has different elimination pharmacokinetics versus fentanyl alone in humans. I feel like you were kind of implying that at the beginning with the rationale for the study, but I wasn't sure because one project I worked on in rats found no difference in elimination kinetics between fentanyl alone and fentanyl with xylazine. Obviously, in humans, it's going to be harder to do that study to have like a fentanyl alone group, but some kind of like opioid alone or something.
Yeah, I think that's like a really good question, and I think I'm unfortunately unable to answer it because 10 out of the 11 participants had xylazine exposure, so it was kind of hard to like compare with and without. And I would imagine that if I did a similar observational study again, that we'd get a lot of people with xylazine exposure again. But I don't know, it could be an interesting, actually, one of the things that a population pharmacokinetic analysis can do is using that covariate search. You can like say like you can find drug-drug interactions is like one of the applications. So if you got a big enough sample, you might be able to look at that. But I don't know. The answer is I don't know. It could be an interesting future study.
Cool. Yeah, or if there's anything out there about like the different study like with elimination kinetics of opioids alone that you can kind of compare it to. But yeah, I don't know how good of a comparison that is, but yeah, interesting. Thank you so much.
Yeah, thank you. Thanks for attending.
When you do creatinine, are you looking at the muscle part of creatinine, or what do you, I don't understand that part.
Yeah.
You look at the muscle part of it.
So it's just
Creatinine excretion.
it's just excreted in the urine.
Okay, so you look at the urine part.
Yeah, the urine part only, and you kind of are assuming that that it's something that it's excreted at the same rate and that it's going to fluctuate with like urine concentration, assuming kind of stable kidney function, which
Right.
was a
That
yeah.
was my next question. So what were these people's basic kidney function when you tested it for excretion rate variable that decreased kidney rate, you may have a prolonged effect?
Yeah. So I know in order to be in the study, you had to have like broadly normal kidney function, but I think that our limit was something like it had to be like less than 2 or 3 times the upper limit of normal, or yeah, so like broadly healthy, but that's, you know, I couldn't really look at like individual if that affected it. I would very much imagine like somebody with complete kidney failure would just take forever, but I don't think any of our participants had that.
Do you use that the cortisol vault for kidney function? No way you can basically that part to see where the kidney function is, just kind of that way versus.
Yeah, we could. I didn't consider that, but I think we could.
The cortisol vault to just calculate the creatinine function, the kidney function based on the BUN creatinine, and then calculate where their actual kidney function is. Could you use that in these people to
Yeah, I think we had one like serum creatinine, so we could probably look at that and see if there's any correlation. Yeah, good idea. You know, I would say I'm gonna stop the recording.